Everyone. It's a Sunday morning, and here we are talking about oats. So, as Angie has introduced, we will be here until about 11:30. The presentation itself takes about an hour and 10 minutes. I will try to wrap it up as soon as possible, and we'll leave more time for the Q&A period. Feel free to type out your question in the chat box. I'll be monitoring it throughout, but some of the question I will defer to answering at the very end instead. Right now, I do see one of the question is about letting Mona in. I'm not sure if Angie or Ellen could help us do that. So then I'm just going to move on.
Okay. Yeah, I'll look into that now. Thank you.
Thank you. So in terms of disclosure, I do not have any current or past relationship with commercial entities, but I did receive a speaker fee from Ontario Pharmacists Association for this learning activity. And this learning activity is funded by Ministry of Health in the form of education grant. In terms of learning objective, it's fairly simple. At the end of this section, we are hoping to achieve the following. We'll review and describe OCP opioid policy for dispensing methadone in particular in Ontario, but we'll also touch upon buprenorphine and naloxone combination product. We'll describe how OCP opioid policy can be implemented in your pharmacy setting. And finally, I'll give you some tips and pearls on what kind of resources and tools are out there to run a dispensing pharmacy for opioid agonist treatment. Our agenda looks packed because I do want to go through every single detail with you from the beginning to the very end, starting from how the training and education could be done for our pharmacists, to getting your very first prescription, communicate that requirement and expectation with your patient and prescriber, to the billing part, preparation of the product, and then eventually we'll graduate to, or clients will graduate to getting carries, and we'll talk about some of the delivery and transfer of custody issues as well. And more importantly, what kind of documentation you should keep for the pharmacy. At the very end, we'll wrap up with a case scenario where I will hope that some of you could participate and share some of your thoughts. Throughout the presentation, we have a couple poll questions as well. They don't need to quiz you, but definitely trying to keep you awake on Sunday morning. And just to be clear, our terminology that we will use throughout this presentation include OAT or OAMT, which stands for opioid agonist maintenance treatment. Sometimes you'll also hear other references to refer OAT as opioid substitution therapy. They both meant the same thing. The more stigma-free terminology, it is OAT. So you do see that more in the later literature. Now, OAT and OAMT comes in multiple forms. They're all opioids. The most commonly seen in Ontario community pharmacy include the methadone maintenance treatment and buprenorphine naloxone sublingual products. So those are two that we'll be focusing on. There's obviously other forms of OAT as well, including slow-release oral morphine. Some of the new kits on the block include the extended release buprenorphine subcutaneous injection and also the implants. And out there in the West, in British Columbia more so, they also do injectable opioid agonist treatment, including hydromorphone or diacetylmorphine. So those three we'll cover in a later topic that will come out in probably next year with OPA. And then in terms of diagnosis, when we refer to clients who are using these opioid agonist treatment, they're most commonly using it for opioid use disorder, which covered by OUD. OAT, though, could also be used for chronic pain management, but that is not a topic that we'll cover today. One more final note is that the disclaimer here is that this presentation is really meant to cover the operation and logistics of dispensing opioid agonist treatment. In terms of the therapeutics and pharmacology of these therapies, I would refer you to different presentation, which is also hosted by OPA at no charge. One of them is titled Opioid Addiction and Substitution Therapy Online Modules, and you're more than welcome to refer to those for any therapeutics and pharmacology introduction. So let's start off with the OCP policy on education and training. So we are all well-trained pharmacists. We went through years of education, and we also have sufficient clinical knowledge and relevant skills with regards to any medications that pass through our hands. However, there exists a policy, such as the opioid policy, that kind of mandates there are special considerations to be made for dispensing opioid therapy. The reason being is that opioids is kind of tricky in that if used appropriately, it does have its intended therapeutic effect. But because it's a high-risk medication, sometimes some of them have narrow therapeutic range, and the risk of diversion or dependence is fairly high as well. Pharmacists should have even more aware of what they do and review any opioid-related education material. And some of those material will be provided on the OCP website itself. They do have a toolkit type of page, and they will go over some of the key points to be aware. But just by being here on a Sunday morning, learning more about what you want to know about methadone and buprenorphine, that is the first step towards getting more education around this topic. So training requirement, we have said that this presentation will cover methadone and buprenorphine. So some of the topics I will cover both at the same time, but where they differ in terms of methadone versus buprenorphine, I will delineate those into separate slides. So in terms of training requirement, the requirements for methadone is different from buprenorphine. If the pharmacy does decide to dispense methadone maintenance treatment, the pharmacy owner do have to notify Ontario College of Pharmacists within 7 days of dispensing. The notification process is extremely simple. You go on the OCP website, download a one-page form, and there you go, you fill it out. The information that they ask is fairly straightforward, such as hours of operation, when do you start, and whether training has been completed. And then the designated manager, therefore, will have to satisfy the training requirement within 6 months of starting dispensing methadone. In addition to that, at least one staff pharmacist have to complete the same training within 1 year of that start date. Both of these individuals should also update their training every 5 years if their methadone dispensing practice is ongoing until then. That every 5-year requirement could even be faster than that if you feel that you need a refresher every few years. The refresher training is at no charge, so I strongly encourage to kind of check in every couple years to see if there's any new updates. The evidence in this field of opioid agonist treatment is still evolving. There is still new medication coming out, new evidence coming out, and new treatment protocol coming out. So it's never a bad idea to keep staying on top of all the new things that are on the market. But in addition to the designated manager and staff pharmacists, I would also strongly encourage you to orient and engage the entire pharmacy team, including casual pharmacists, weekend pharmacists. Your pharmacy technician and assistants are great help as well. They don't necessarily have to take the entire course. However, it's just showing them what the operating procedure is, letting them know what are the key points to know. After you go through the course, you could even write down some pointers and develop your own mini orientation for these staff members. So in terms of the training course, what satisfies that training requirement? For the initial training, there is only one option really, and that's where the designated manager and the staff pharmacists have to complete within that first 6 months and 1 year. That training is offered by Center for Addiction and Mental Health, or the CAMH, and is titled Opioid Use Disorder Treatment Course. Since the pandemic started, this course has gone completely online. There's no live portion anymore. The enrollment rate has also increased. So I know prior to that, there's always an issue for waitlisting because the course cannot take on as many attendees as they can. But now there is no such issue. So as soon as you sign up, you should be able to get a spot within 2 to 3 months. The course takes place over 7 to 8 weeks. You can take it at your own time or pace, and includes 5 to 6 modules covering everything from therapeutics, pharmacology, operations, and also monitoring requirements, such as some of the lab work stuff. There's also a discussion board and some deliverables that you have to commit to, but those will be monitored by a practicing prescriber and also the practicing pharmacist and nurse practitioner. So if you do have questions during the course, they are still being reviewed, and you can still have that interaction with all the professionals that's into this topic. So in terms of renewal training, which is the 5 years later training, you could also try one of these opioid addiction education courses. So there are 2 options, including the opioid addiction and substitution therapy online modules, or the live one-day program, methadone, buprenorphine, and the community. Both of these training are offered at no charge, and they're not really interchangeable. They do cover different topics. I do find the material quite interesting as well. But even for the renewal, you can also take the ChemH course again, which gets updated every year. To take the renewal training, there's no requirement that you must complete the initial training. In fact, anyone can sign up for the renewal training without any prior knowledge of opioid use disorder treatment. So for the links of the training, they are, if you download the course material, there is actually the link to the website already. When we do dispense methadone in our pharmacy, there are some required references, and these references will be checked if you ever get an OCP audit. The first one that you have to have on hand is the ChemH guide, which is titled Opioid Agonist Maintenance Treatment. Unfortunately, this book comes in hard copy only, so you do have to purchase it and keep it in your dispensary. It's about $70 and it's available through the ChemH bookstore. The other 2 references are this published by CPSO, so the College of Physicians and Surgeons Ontario, and they are both available online, which goes over the guidelines on prescribing as well as the policy on dispensing methadone. So that's for the methadone maintenance treatment. Next, we're going to go into buprenorphine and naloxone therapy. In terms of training requirement, there's actually nothing related to buprenorphine therapy. However, it's strongly recommended that you go through the same educational program as if you were dispensing methadone maintenance treatment. The programs that were highlighted previously actually, like this presentation, they cover the 2 main opioid agonist treatment. And some of the treatment principle, protocol, the monitoring is similar to methadone. So if you are going to dispense buprenorphine therapy, it's never a bad idea to know the knowledge for both, because you will see clients who may be switching from one to the other, and maybe you will even get clients on some on the methadone therapy and some on the buprenorphine therapy. Again, also let your team know what your standard protocol is. In terms of buprenorphine and naloxone therapy. It could be different from methadone in terms of the observed dose and the carries and so on. But again, because it is a medication that carries its own risks, it's always good to let the pharmacy team know what your preference is and how you set up the pharmacy to dispense these. In terms of recommended reference, again, there's no mandatory requirement for dispensing buprenorphine and naloxone therapy. Even the reference is a recommended one only. I will still ask you to do it because it's something that's online. It's a PDF document that you can download. Again, the link is with the handout. If you click on the link, it will direct you right there. The reference itself is pretty helpful because it does cover some of the initial titration module protocol and also some of the dispensing tips as well. Okay, just a quick check-in here. If there's any question about education, please feel free to type out your answer. If I cannot cover, I didn't cover it now, I will leave that to the very end and cover those. Next, we're going to jump into some of the operation stuff. Let's say there's a client that comes in with the written prescription for either methadone or buprenorphine therapy. What should we start checking for? So in terms of prescription requirement, it does have to satisfy all the prescription requirement for any other medication. So it should have patient name. Because it is a controlled substances, it does need a second identifier, such as an OHIP number or ID number. It should include the name and dose of the medication, the instruction of how to take the medication, The instruction of use as directed is not appropriate for methadone or buprenorphine. They should specify the daily dose, how it should be taken, and also the frequency of the dose. The prescriber name and the contact information, as well as the date of the prescription, should all be part of the legal requirement. Now, going into the middle column, there's also the CPSO standards and CAMH guideline. These are actually required as well. So they should be all on all the prescription that is prescribed for opioid use disorder. So there should be the start and stop date of the medication. So you will commonly see methadone is being prescribed either on a weekly basis, and the times now they do get prescribed even on a monthly basis. But they should indicate the start and stop date so that you can calculate the total quantity. And they should also specify any days of the week that needs to be observed versus taking a carries home. So these are requirements if it's used for opioid use disorder. There are some clients who are getting opioid agonist treatment for pain management. It's good to still include the total quantity, but sometimes these patients will not get any observed doses and they will take everything home as carries. Knowing that indication, what it's used for, whether it's for opioid use disorder versus pain management, it will be important. Most of the time it is indicated on the prescription as well. If not, it's always a good idea to check in with the doctor or the patient themselves. And finally, I just want to touch upon the best practices. These are not required, but it's obviously going to be helpful in terms of communication between the prescriber and the pharmacy. So it's always good to spell out the dose in words. So instead of like putting just 80 milligrams, spell out the word 80, especially if the prescriber is using written prescription, like a handwritten prescription, instead of the electronic ones. This is just to minimize any misinterpretation of the numbers being written down. They could also include information about changes in doses because we don't share electronic record. We don't have an up-to-date assessment of what the conversation is between the physician and the patient. We don't know the clinical changes. Sometimes we are not sure why the prescription dose has been changed from before. So some prescribers do have that preference of writing down if this dose has increased or decreased, just so the pharmacy is aware as well. And finally, the pharmacy information is not a requirement on the prescription. Technically, a client can walk in with a prescription and it says methadone, give you all the rest of the required information, but it doesn't say it has to be dispensed at your pharmacy. This is especially true if the client has attended to like one of the emergency department or one of the RAMS clinic. They might come out with a prescription that doesn't have a specific pharmacy information on it. They're still legit prescription. Our job really is just to make sure that the prescription is authentic and prescribed as intended. And we can still accept that. In terms of whether the prescription has to be faxed to your pharmacy versus hand over to you by the patient, there is no specific requirement anymore. At this time, Health Canada has exemption for controlled substances prescription, including methadone and buprenorphine. So they could fax your prescription. The doctor could also call in a verbal for these prescriptions. If those are the case, again, our job really is to validate whether these prescriptions are legal and coming from an authentic prescriber. So who can be the prescriber for methadone and buprenorphine therapy? A couple years back, this is a little bit more restrictive. In order to prescribe methadone, the prescriber had to kind of register with Health Canada, obtain something called the exemption. This is no longer true. As of 2018, the exemption is removed. No one need to like register with Health Canada anymore. However, as I mentioned, this is ideas that I mentioned previously. Because opioids are such a high-risk medication, we still want to ensure prescribers understand these medications and have the required knowledge to prescribe them appropriately. So according to CPSO, the College for Physician and Surgeon Ontario, they do have certain requirements where the physician and residents have to meet before prescribing methadone. These requirements are unfortunately not listed on the CPSO registry website. but they do ask that the physician to give a written notification to CPSO indicating their intention to prescribe methadone. They should also complete the same CAMH course on opioid dependence and treatment course. They also need to complete a 1-day preceptorship with a methadone prescriber, or similar to that, a simulation course, which is offered by CAMH, so they can have some practice experience before prescribing their own methadone prescriptions. And then they should expect that into 1 year into their practice, the college could audit their practice and just check in with them to see if they are doing so appropriately. Similar to our practice, that they should be confident and knowledgeable about what they're prescribing and have the appropriate monitoring guidelines for their practice. In terms of residents, they are mostly working in hospitals these days. They used to be not able to initiate any methadone therapy, but that has also changed since 2018. Just like the physicians, residents could prescribe methadone, initiate methadone, restart people on methadone if they have completed same training requirements. So they completed a course, they have shadowed someone who prescribed methadone, and they are confident and knowledgeable about this. And then finally, we have a new class of prescribers, which are nurse practitioners. So these days, as of 2018, nurses have obtained the scope to prescribe controlled substances, as long as they have completed the required education program as well. So College of Nurses of Ontario do list the nurse practitioner's training certificate on their website. So if you search by a nurse practitioner's name, it does display that they have completed required training and they are eligible to prescribe controlled substances, including methadone. They are also strongly encouraged to take the same CAMH course so they can understand methadone and buprenorphine prescribing as well. The nurse practitioner, the certificate is usually called primary care certificate, and you will find it under their specialty certificate training on their website. Okay, but all in all, what is the pharmacist's role in all of this, knowing that who are the prescribers? I would say that the pharmacist is not really up to the pharmacist's responsibility to be policing and verifying the training completion of these prescribers. Whenever we receive a prescription, our job really is to validate the authenticity of the prescription and the prescriber who are providing the prescription. So if we do get it from Dr. X or a nurse practitioner, we first need to validate if this practitioner a licensed practitioner, and is it prescribed it for the intention of treating the right client. In terms of training requirement, we do not need to ask for sending your certificate of training to prove that you have completed education. If you do find that there is any knowledge gap or things that could be improved, feel free to share your resources with these prescribers, because as I said, things are still evolving so quickly. There could be some new knowledge gained on both parties. Okay. Let's jump into a polling question. So I'm going to launch this poll and we'll take about 30 seconds to answer. It's a very simple question. What do you think if a prescription for methadone or buprenorphine written by a province prescriber, can it be dispensed in Ontario? Okay, I'm going to close the poll now. Thank you for all of those who have answered. And the answer for this, as majority of you have answered correctly, is yes. Okay, so any prescription written within Canada is valid to be filled in Ontario. Again, we want to check whether this is coming from a legal prescriber or legit prescriber. You may be able to check from their own province College of Physician website. So different provinces have different registry. Most of them are online, and you can check whether prescriber is actually licensed. Make sure that the prescription has all the legal requirements as always, and we will verify against the patient, making sure that they have the right ID and is intended for this medication as well. And finally, if we can obtain contact information of the previous pharmacy, either from the prescription, from the prescriber, or from the patient, that will be much preferred because you want to validate some of the questions like when is the last dose and what are some of the tips or things to watch out for this client, some of the medical information as well. So moving on. So because there are so many members involved in the care of one patient, not only for methadone and buprenorphine therapy, but in terms of all medication, we just want to establish that circle of care where information could be shared and questions could be asked. And for opioid agonist treatment, I find this particularly important. Clients on opioid agonist treatment typically do experience more stigma than patients on any other medication. So it is important to have a supported environment for the patients to visit your pharmacy and receive care in their journey of recovery. So the pharmacy should really be set up with sufficient private areas for observed dose and one-on-one conversation. And do take the time to work with these patients and their prescriber just to make sure that they're on the right track and they're adherent to their therapy. So between the pharmacist and the patient, we have talked about the open communication, but between the pharmacist and the prescriber, it's also important to keep each other up to date. Pharmacists actually may see the patient more often if they do come in every single day. Prescriber might check in with the patient once a week or once every 2 weeks. What you observe in the pharmacy is very important to pass it on to the prescribers because it can impact their assessment. Things include if they miss any doses, if there is a pattern that is developing, or even your clinical assessment. Are the patients feeling more depressed, or do they have more mood issues lately? What you see on a daily basis do help the prescriber to make the judgment for further therapy. It's also important to establish that communication channel with the prescriber. A lot of the times the prescription might have the office phone number. However, that phone number often leads to a receptionist or a voicemail box. If you have a lot of clients working with this prescriber, it's worthwhile to ask for a second method of communication, including emails or even personal phone number, which is not meant to be called every single day, but in case of emergency, you guys have worked a plan together of what to do with some of the emergency situations. There are times where family member or caregivers of the patient want to be involved in the care, which is fine as long as the patient has agreed and consent to it. And I would say it's very important to document these conversations, whether you obtain consent and who the patient allowed to be aware of their therapy. So your clients may be living with a number of household members, but they don't always want the household members to know what medication they're on. So they might even ask you to have a different phone number on file so you don't call their home and inadvertently letting them know that they are using your pharmacy service for this kind of treatment. So it's good to have that conversation early on with your patients just to have that ground rule set up between the two of you. However, if the patient is completely okay letting a family member in on their therapy and treatment process, that's okay. Again, document who is allowed to know this information. You may also get phone calls or like the police showing up and asking you more information about this patient's medical information. As with all other medication, we're not allowed to share any medical information unless there's a court order when it comes to any legal cases. However, if you're receiving a call from a different doctor or ambulance calling or paramedics are on site, feel free to share relevant medical information because it can impact the patient's care in an emergency situation. So just share what is relevant, such as their methadone dose, how much they have consumed, how long they've been on therapy, and so on. But you don't need to share like the entire life of the patient. So some of the communication tips we have highlighted between that circle of care, and I will say that's really a key part of what we want to focus on, developing a long-term relationship with the client, because they will use your pharmacy service very frequently for a longer duration of time. Within your team, make sure you do document tediously everything that you know about the patient. Our dispensing software are quite well developed now. You have plenty of space to make notes. You can make some notes pop out. This is not. So do use that to serve as a tool between you and your team member. And do review those notes whenever you have to have a conversation with your patient. Between you and the patient and between the team and the patient, always be respectful, have that private space available. And we also talk about some with the prescriber having different methods of communication in case you cannot always reach them by phone immediately. Okay, we're going to move into something called treatment agreement. This is something that must be signed for every client that receives methadone therapy or buprenorphine therapy at your pharmacy. It is more like a tool to help you establish mutual expectations, so some of the ground rules for patients using your pharmacy. It's beyond the regular like therapeutic counseling. You don't need to go over it will make you drowsy, do not drive in the agreement. What you do want to cover are some of the logistic stuff. So things like hours of operation. You might be open 24 hours, but if your staff is a little bit thinner at the end of the day, you might ask the patient to come earlier in the day when there's more staff around. You might want to set up rules about what to do on the weekend. They should be coming within certain hours or so. And also there's also you can put in things about behavior and the payment setup in the agreement as well. It can be a very long document, but it has to be completed. But it can be completed over several visits. I'm going to show you one of the sample that is from the reference I referred to earlier, which is the Pharmacist's Guide to Methadone and Buprenorphine Therapy. This is the book from the ChemH bookstore. So in the appendix, it does share some of the sample treatment agreement. It can be a long document, and it should be customized to what your pharmacy does. It could be like a page to a page and a half long. But depending on the time you have with your patient and how applicable it is to your patient, some points might not be relevant at that point in time. So if the point is talking about caries and the patient is not receiving any caries at this time, we can skip that point and come back to it later. So make sure you have this on hand for every client that's signed. It does not have an expiry date. However, with any changes to the points in here, it's worthwhile to revisit that with your patient again. So I know during the pandemic, many things have changed, including hours of operation, including what to do with returns of the methadone bottle, or how the observed procedure should go. So those could be added to the revised treatment agreement and review with your clients once more. Okay, so next we're going to jump into this topic about billing. This topic was quite complicated yesterday, and I did get quite a bit of question. Before we go in, let's do a polling question. Let me launch that. Again, we'll have about 30 to 40 seconds for you to complete this. The question is, could claims for a methadone prescription to ODB only be submitted on the day of intended ingestion date? Nope, the polls are very tight right now. I'm gonna give it another 5 seconds before I close the poll. So majority did get this question right, which is false. The claims for methadone prescription do not have to be submitted only on the day of intended ingestion date. And we'll go over the details of that coming up. Okay, so in terms of billing, ODB does have um, actually a guidance document on methadone and buprenorphine therapy. So I'm going to go over some of the key points through there. And the reason I go over ODB is because most of the clients who are on methadone maintenance therapy or buprenorphine tend to be on these medications for long term. And for financial reasons, most of them will be applying for ODB. And that's why you do encounter the billing issue to ODB more frequently. So for ODB, for methadone maintenance treatment, whenever we submit the claim should be in the quantity of the stock solution in milliliter. So say, for example, a client is on a 75 milligram dose, then that claim should be submitted to ODB 7.5 milliliter of the stock solution. Stock solution usually come in 10 milligram per mil, but there are pharmacies that use 1 milligram per mil as well. Now, this can be tricky because you may say that some pharmacies dispensing software do not allow decimal billing, especially if a client's on a greater dose like 72 milligrams, so you'll end up with a 7.2 milliliter. But in fact, you can call your software vendor and they can adjust that in the back end. You can continue to bill 72 milligrams, but in the back end, they actually divide that number by 10 and actually submit the claim to ODB at 7.2 mil. So that's something that is customizable, and all three of the like the big software vendors I know of, they are able to customize this. You are allowed to claim 1 dispensing fee per day, regardless if the dose is for observe or for carry. That means if the client is coming for 1 day of observed therapy and 6 carries, you bill all of those in the same day, but you'll get 1 fee for each of those claims. Now, when you process those claims, you will obviously get a response message saying duplicate therapy, and you can override that message using the intervention code UA. The dispensing fee the 1 dispensing fee per day will also apply if the client is on more than once daily dosing. Some clients may be getting methadone therapy twice a day or even 3 times a day. You do have to submit 2 or 3 claims for that day just to print out all the labels for that and have the instruction for each of the bottles. But make sure that only the first claim you submit for that day has the dispensing fee, but the subsequent 1 or 2 prescriptions do not have a dispensing fee. So the bottom line is 1 dispensing fee per day, regardless of the dosing frequency, regardless if it's observed dose or regardless if it's carried dose. Okay. Even though it is a product that requires a little bit of preparation, you're putting the stock solution and then the diluent in, it is not considered compounding, so you do not get a compounding fee for this procedure. Under the ODB guideline, we're also not allowed to charge the copayment to the patient. So that is referring to the $2 or the $6.11. We cannot charge that on a daily basis to the patient. However, if those copayment that are showing up on the receipt is part of the deductibles, such as the $100 annual deductible or the quarterly Trillium deductible, then yes, do go ahead and charge those. Until the deductible has been satisfied, then we cannot charge the copayment. This policy of daily dispensing fee and copayment do not apply to exceptional access products. So that means things like the methadone tablets or the indication for pain management. So in those scenarios, then you could charge less than 1 daily dispensing fee and also charge the copayment to the patient. I do want to highlight the interim federal health plan, which is not on the slide here. So there are clients who are with refugee status and is submitting their claim to the IFHP plan. Their plan do allow daily dispensing fee for methadone as well, but the problem is you cannot forward bill. You can only do the day of billing or backward billing. So what that means is that if the client comes in on Monday for their observed dose, but is supposed to have carries for Tuesday and Wednesday, you cannot bill the Tuesday and Wednesday dose on Monday and get a fee. You can still bill it, but on Wednesday, you will have to reverse those claims and bill it again just to get the dispensing fee back. So it does not allow you to forward bill into the future date, but it does allow you to backdate and get that fee. In terms of private payers, so we do have clients who are on methadone and buprenorphine therapy that are using private insurance as well. Most of the time that I've encountered these, you do require a call to the insurance company because they might need pre-authorization to get that daily dispensing fee set up. Some of them may not be willing to reimburse daily dispensing fee even, so they might only do weekly dispensing fee or something like that. But the private insurance plan is just different between one and another, and you most likely have to call. Switching gear to the buprenorphine part, similarly, let's do a pre-question on this. So when providing 6 days of buprenorphine carries, a dispensing fee to be claimed for each day of supply. Is this true or false? Many of you have to answer so quickly. I'm going to close the poll in about 5 more seconds. So again, you already know this. The answer is false. You cannot claim a dispensing fee for each day of the carries. And we'll go over why here. So there's so Noah had to have a question about methadone billing through patients with status. If you mean refugee status, using the IFHP plan for methadone prescriptions, you can only bill backward or the day of for that dispensing fee. They do pay dispensing fee on a daily basis. However, you cannot bill forward, so you cannot bill for tomorrow's dose or the day after. This can be a problem if they are getting carries. You will still bill the day that you give out the carries, but the once the time lapse, like say tomorrow, you actually have to reverse that claim and bill again, so you can get the dispensing fee back. I can cover this later on in the more details if you still have questions about this. But let's jump into the buprenorphine part. So the billing for buprenorphine is that you get one dispensing fee per strength of the tablet per day of the witness dose. Okay, so that means the day of the observed dose, you will get a dispensing fee for whatever you dispense. You'll also get one dispensing fee per strength of the tablet and per day of the carried dose that are all dispensed in one day. So I'm just going to give you an example here, which may help you visualize this a little better. If a patient is to get 10 milligram buprenorphine dose daily, and they're supposed to observe Monday and Thursday and carry for the rest of the days in the week, this is what you will claim on the Monday, which is the day of the observe. So for the observed dose, you will bill for one tablet of the 2 milligram, one tablet of the 8 milligram. You will get a dispensing fee for both of those. Now you're going to prepare their carries, which you will need 2 days worth of 10 milligram doses. So you bill 2 of the 2 milligram tablets for one fee, 2 of the 8 milligram tablets for another fee. So that Monday, you're getting 4 fees, but you are dispensing 3 days worth of supply, including that witness dose. Comes Thursday, you will repeat the same thing. So you'll get 1 fee for the 2 milligram tablet for the observed dose, and 1 fee for the 8 milligram tablet for the observed dose. That's Thursday. But Thursday, you also have to prepare 3 days worth of carry. So you're going to dispense 3 tablets of the 2 milligram for 1 fee, and 3 tablets of the 8 milligram for another fee. So you also get another 4 fees for Thursday. Okay. So for the observed dose, you always get that 1 fee for the observed dose. But for carries, regardless of how many days you are dispensing in, you will only get 1 fee for that lump sum of carries. And again, because you're processing more than one claim in that one day, you will get the duplicate therapy message, and you can, again, override it with the intervention code UA. So make sure you review these duplicate therapy message carefully as well, because sometimes they do flag like NMS message if they fill another opioid and another pharmacy, or you do have to decipher like whether that UA is appropriately used. It's only good if it's for multiple days. It doesn't apply to same day, like the doses for same day, like BID dosing for the second dose for that day is not appropriate to use UA. The copayment from each claim can actually be charged to the patient. So this is a little bit different from the methadone treatment where the copayment cannot be charged. So you can charge a $2 and $6 limit to buprenorphine clients. And similarly for private payers, it does require a little bit more work, and you do have to call their individual provider to figure out how much they pay. Okay, so that's the billing. Probably the most math that I will do for the Sunday morning. In terms of pharmacy setup though, we're going to go over that. So we have already talked about including private spaces for conversations, and sometimes the administration of those will, the clients will prefer a little bit of privacy as well. Especially some of the clients may take up to 10 minutes for some of the tablets to dissolve in their mouth, and they may not be wanting to sit in the open waiting area. So it's good to have a private space to allow them to spend some time there. Other pharmacy setup that we should account for include the secure storage of controlled substances, including that because the methadone bottle can be quite large, as well as sufficient spaces for all the buprenorphine that you'll be keeping on hand. Preparation of the methadone doses or even the buprenorphine doses should take place on a clutter-free and clean counter. This is, I think most pharmacy are working towards the paperless state of their dispensing software. But whenever we prepare methadone or buprenorphine, there are just so many bottles for different days and different labels. Just make sure you have a clean area to work with those, because it can be messy. Also, I would suggest having a collection bin behind the counter to collect any returns from the client, such as like the cup that they just drink from, or the little Dixie cup that they got their buprenorphine dose from. Just place the bins behind the counter where they can reach their hand over and drop into the bin. That will minimize contact with our pharmacy staff as well. But it has to be out of reach from the public, so then they cannot go through the bin and collect whatever that's remaining in there. This is the final polling question I have for you. And then after that, we'll continue through all the slides. Launch this poll. So those preparations should take place in front of the patient, having them as the witness whenever possible. Is this true or false? Okay, I'm gonna close the poll now. So thank you for all of you who have answered. You are right, this is false. We do not have to do this in front of the clients. They are not our witness. If they want to know, that's fine, but then the preparation should actually take place in a discreet manner. So in terms of preparation of dose, we actually prefer to prepare the dose whenever possible after the client has arrived, because the pharmacists do have to conduct that mini assessment before providing the dose to the client. What I meant is that you want to check in if the client is looking well that day, is not in any intoxication status, they're appropriate to receive the dose for that day. And also you might need to check if there's any clinical interaction for them to receive the medication for that day as well. So that's why after the client arrived, then you go ahead and prepare the dose. However, I understand that some pharmacies do have a large volume of clients coming in for observed dose, especially in the early morning, and there might be need to prepare ahead of time. So then you don't get this lineup of running back and forth, trying to prepare those, check the client, and so on. If you do prepare doses ahead of time, make sure all the labelings are as organized and as accurate as possible, of course. We want to avoid that. You want to grab the bottle and run to the client, but it's not the right bottle and not the right dose. So things like that require a little bit more planning and just a bit more organization to get set up properly. In terms of measuring of the dose, it should be done on a counter that is kind of away from public access as well. Given the physical space constraint in certain pharmacy, it can be challenging. You might have to place a bottle like in a counter that is kind of where the client can reach over. That's definitely not ideal. If that's the case, make sure you have some way to secure the bottle. But otherwise, try to do it in a discrete place. Your compounding area would be nice. And who should be dispensing is that pharmacists could definitely do this independently, measure out the dose, prepare the dose, and dispense the dose to the client. However, if you are involving registered pharmacy technicians, then you could have the pharmacy technician check on someone who prepared the dose. So the technician should be checker. It could be a pharmacy assistant, or if you could partner up with the pharmacy technician to prepare the dose together. However, the pharmacy technician is not allowed to dispense it to the client. What that means is that grabbing the bottle and handing it over to the client. The pharmacy technician should not do that because that handing over piece requires a clinical assessment. Pharmacist should be the one that's doing it and assessing if the client is appropriate to receive those doses. Similarly, for observed doses or administration of the doses, pharmacy technician cannot be the one that's observing the dose. It has to be the pharmacist as well. How do you refuse to give the dose and what happens after? So let's go over that too in a few slides later. Let's continue with the measurement piece. Because, like I said, methadone is such a high-risk medication and does have a very narrow therapeutic range. We just want to ensure that as accurate measurement as possible. So you want to use devices that can deliver small volume, as little as 0.1 milliliter increments. Okay, the recommended device includes calibrated pumps, which is what is shown in the picture. Some larger pharmacy or people with a lot of clients on methadone, they might even use a automated system called Method Measure, which hooks up to a stock solution bottle and a tank of juice, and they will mix it together and deliver it in a bottle. So that's a little bit more advanced. But for smaller volume pharmacies, using oral syringes is fine, as long as the syringe is able to measure 0.1 milliliter increments. What's absolutely not appropriate is graduated cylinder. They are not accurate for measuring volumes in small volume. Now, when we purchase these equipments for measuring methadone alone, it does involve a little bit of capital investment. So the calibrated pumps is typically around $700 to $1,500 each. And because it is quite a bit of money, you just want to make sure you get the right one. So the pumps, there are different factors that you have to check for. Make sure you buy the right volume range. So the picture here shows a pump that can deliver between 1 to 10 milliliter, which is fine for most of the methadone dose. Typically, they're around 70 to 90 milligram for methadone doses. There's obviously larger volumes, so if you do need to measure a 15 milliliter dose, you can either break that down in two pump, so like 7.5 mil each. But if anything that falls out of the range, you just have to be a little bit creative, either add up to that dose or use an oral syringe to measure out that small increment. You could not use two syringes with 0.1 millimeter measurements, so we do have to stick to the 0.1 millimeter for the syringe whenever, like no matter what volume you're measuring in. Okay. And also another thing about those pumps is that whenever you're purchasing them, some of them only dial up by 0.2 milliliter increment, but you do want the one that dials up by 0.1 milliliter increments only. When we have more tools and equipment on hand besides oral syringes or even oral syringes, you just want to review the procedure with your team as well, because you will not be the only one who's dispensing. They need to know how to use the pump accurately, how to do the priming or cleaning regularly as well. And some of these more advanced devices do require annual calibration just to make sure they do deliver the accurate dose time over time. There are companies that does the calibration services or the vendor themselves, like where you purchase it from. Annual calibration is recommended. They do send you a certificate of like this pump has been calibrated and it delivers accurately. Keep those documentation because OCP might ask to review them. Okay, so next we're going to go into diluent. This is a hot topic. It's also the question that I get very often. Strangely, it's not about methadone, it's about juice. So all methadone drinks has to be diluted in some form of diluent. We can never dispense the stock solution alone, regardless if they're traveling or have different kind of reasoning. Do not dispense methadone in stock solution format. Each dose should be diluted in about 100 milliliter of diluent, and it doesn't matter what type of diluent you use as long as it cannot lend itself to injection. So besides no water, no sodium chloride, you can use any of the juice that's listed or not listed on here. Try to keep it to a minimum at your pharmacy, like in terms of selection. You're not trying to operate a menu of different juice available. Just try to make it easy for your staff and keep it simple to maintain as well. The reason for keeping the stock solution has to be diluted is really for two purposes. One is that methadone is extremely bitter if you drink it on its own. So you always want to dilute it in something sweet. And diluting it in that 100 milliliter of volume is important because that will also help reduce the bitterness. The second reason is to prevent diversion. As I said, the stock solution itself can be easily diverted and can be misused either as injection or diverted to someone else. Okay. So different diluents have different expiry dates as well. Methadone itself actually have a very long expiry date and it doesn't change no matter what you dilute it in. What determines the expiry date for that mixture is actually the juice itself. Because it's a sweet juice and it's aqueous base, it's prone to bacterial growth. So that means whatever juice you use, that will determine its expiry date. I listed different numbers there. They have been studied a little bit before. That was a long time ago. But under the NAPRA best practice, we just assign a beyond use date of 14 days in refrigeration. That's a very interesting question. Can patients bring their own orange juice to mix? My answer would be no, I do not want to get into any responsibility. You did not prepare that orange juice. You don't want to take accountability for what goes into the juice as well. Of course, they can bring you like a fresh box of juice that's not open. It's really up to your discretion. I would say try to limit the choices of juices in your pharmacy. You don't want to open up the fridge and have 5 different selections for different patients. Just really to keep it simple. It's for your own operation as well. And what should we do if patients that want less than 100 milliliter juice? That's a great question, and I'm going to go over that with you right now. So whenever we observe dose, we want to use a disposable paper cup or plastic cup that can hold at least 100 milliliter of volume. And you always want to put 100 milliliter of volume. You just don't want to put your pharmacy colleague in the position of like, oh, but the other pharmacists give me less juice. We want to be consistent with the client. 100 milliliter is the standard, and there shouldn't be that much negotiation room with it, unless they have a medical condition where there's fluid restriction. Okay, so some client may have a heart condition, they might not be able to drink 100 milliliter fluid, that's fine. You can reduce it to 50 ml or even less, but we always want to keep 100 milliliter because for the reason that we have mentioned, the taste and also the diversion volume. But also when you're observing them, there's also the chance of cheating the methadone juice or the mixture. In smaller volume, it's easier to cheek, but in larger volume, they have to swallow the whole dose. Okay, and also even for the carries, we always want to keep it at 100 ml as well. That's what the bottle is designed for. We don't want to reduce any volume at all. Okay, if the client do insist of getting smaller volume, this should be agreed upon with the physician as well. We just want to wonder what's the reason? Is it the taste or is it something that has to do with their medical condition? So some people may have very bad GERD and they cannot tolerate as large of a volume. But you want to be consistent. That's the key point, so they don't always make these requests with different people. Okay, in terms of buprenorphine observed dose, you can serve it in a little Dixie cup or in the vial, where they can tip over the bottle or the cup into their mouth, and so the tablet lands right under the tongue for the observed dose. But for carries, for both methadone and for buprenorphine, all the carries should be in child-resistant caps, and you can even add like tamper-proof caps or seals on there just to make sure that no one opens the bottle when it's not due yet. And you can always check if the seals were broken. Again, the child-resistant cap is a mandatory requirement for the pharmacy. You could waive it for certain patients, say they have arthritis or they have some disability that is very difficult for them to open the child-resistant cap. Again, this is a risk that the pharmacy have to bear. If you do decide to switch it to snap caps or blister pack for them, and it does lend itself to diversion, you do want to document that because it will come back to the pharmacy. Why is it not in a child-resistant format? Some patients do ask for patients who are on buprenorphine. Sometimes they may ask for the tablets to be cut as well. So you may want to have a separate pill cutter for buprenorphine and naloxone tablets only. So you don't always have to wash it in between and when you use it for other medication as well. Next is the labeling requirement. So I do want to highlight some of the specific requirements for methadone and buprenorphine as well. They do need to have all the required prescription label requirements, such as date of the dispense, and then doctor's name, patient's name, and so on. What I want to bring your attention to is actually the instruction. So for methadone, you do have to put down instruction like drink the entire contents of this bottle at once. This is because there are mistakes previously where if you don't put that, they actually dispense only a small portion of that bottle only, because you might notice that at the bottom here where they put the drug name and the volume that was dispensed, it says 8 milliliter of methadose and the concentration. Most of the time it's patients handling those bottles themselves, but there were times where a caregiver might be retrieving the dose or someone administering the dose to the client. If you don't put down drink the entire contents of this bottle, they might measure out 8 milliliter and administer 8 milliliter only. And obviously that is a severe underdose, and they're not receiving the full benefit from that drink. Another mandatory requirement for methadone label is the ingest date. So for all the carries, you have to have separate labels for all the different ingest date for those bottles. Even though there may all be 80 milligram doses, you still have to have those dates available. The reason being is that sometimes these clients have to bring the doses to a different facility for storage or for safekeeping. And they might only release one bottle to the client a day, and they have to go by the date. It's also a good practice to indicate the total dose in that drink. So again, there might be confusion of the 8 ml versus 80 milligrams, so you want to be clear whenever possible. Some patients who get split doses, like morning BID dose or even TID doses, you will have to have a separate label for each bottle as well. Do not combine all the doses in one bottle. And sometimes the morning dose is a different dose than evening dose. So in those situations, also put it on the label. This is for the morning dose versus like this is for the evening dose. Another mandatory requirement, so there's a lot of mandatory requirement for methadone labels, is the auxiliary labels. One of them is in the red one, which is methadone may cause serious harm to someone other than that's intended, which makes sense. We just want to make sure the bottle doesn't end up in the hands of someone else. You can also keep it in refrigerator label or shake well label on the bottle as well. Those are not mandatory, but it's a good reminder because after it sits for a while, the methadone and the juice do separate a little bit. Expiry label, it's more relevant if in this pandemic situation because the number of carries do increase, what I observed so far. So sometimes people may be picking up a whole month worth of carries at once, and you might want to put a beyond use date label on that. We will have a second presentation on pandemic precaution in 2 weeks, and you're more than welcome to join. I don't think we'll have enough time to go over all the pandemic precaution today. So what if patient asks for a loose label to peel off later for privacy reason at home, and that is not appropriate? Unfortunately, we cannot dispense something that's not labeled. It's a legality issue. If they do have privacy concern, they could bring a lockbox. They could bring other type of storage container to kind of conceal what they're getting. But we should not dispense anything that's not labeled because it will come back to us. For buprenorphine, there's less mandatory requirement, but I will go over some of the best practice and also probably something that will help you avoid confusion and help the patient as well. So for the instruction of buprenorphine, you will always write allow X tablet to dissolve under the tongue or dissolve X tablets under the tongue. Just to emphasize that it's something that's absorbed under the tongue. If they swallow the medication, there is actually minimal absorption and therefore it's not going to help them. Sometimes the clients will be getting 2 different strengths of tablets as well to make up for the total daily dose. So I usually like to indicate the total daily dose on the label as well, just in case if someone is administering for them, they are not missing 1 bottle and did not give them the total dose that they need. It also requires ingest date in that you don't have to separate the carries into its individual daily portion. Okay, all the tablets can go into the same bottle for the carries for that same strength. So like you can put like 12 tablets of the 2 milligram in bottle and then 12 tablets of the 8 milligram in 1 bottle, and those tablets will last them for the duration of what's on the label. So I'm just gonna be running through the next few slides very quickly so we have enough time at the very end. We had talked about clinical assessment earlier. Pharmacists should be doing a little clinical assessment before handing out the dose, mainly about the intoxication, but also about missed doses as well. So you wanna have a record on hand just to see how many doses had they missed in the previous days. There are, depending on the number of days missed, there are different procedures. So like sometimes it warrants a cancellation of the remaining prescription, but sometimes you might just need to inform the prescriber that they missed 1 day or 2 days. So always have a dosing record handy so you can quickly refer to it. If the patient did not come to your pharmacy for the last dose, you also want to check on the timing of the last dose. Some pharmacy that operates 24 hours a day, and the patient say come very late last night and show up first thing in the morning, you also need to confirm the timing. So methadone cannot be administered within 15 hours of the previous dose if the client is on a once daily schedule. If the client is getting new prescription that day or stopping medication, you also want to do a quick check on any drug interaction that may be present. So missed doses, there's various ways to confirm. The most easy method is actually having that record at your pharmacy at the dispensary table for easy access. You can also check whether they had, if they do bring back the return bottles, you can check whether they have consumed everything. If it's from another hospital, another pharmacy, then you can check for the receipts or call them up. The hardest part is actually hospital and detention centers, where the client might have been admitted or temporarily held in another facility. They're getting better with a discharge summary showing when the last dose is, but if they are not available, make sure to call them up and ask for the last dose information. It does take a little bit more time. This is also another education point that you might want to share with your clients, just to let them know if they are ever going to any other places beside your pharmacy for doses, either because they got admitted or in a detention center, ask for proof of dose record, or if they didn't get any dose, they have to ask them for like a issue letter of like, due to this reason, dose has been missed for 2 days. That will save you time and save them time of waiting as well until you confirm the details. What if you cannot reach them? That's always the hard part and always happens on a Friday evening. I totally understand. For hospital and detention center, it is the responsibility of the dispensing pharmacy to check when is the last dose. If you absolutely cannot reach them, you can only refer the client back to their original prescriber. Or even the rapid access clinics where they can do a bridging prescription. The risk is that it's always better to underdose rather than overdose, especially if you cannot confirm when the last dose is. And if over time you do notice a pattern of missed doses, like the client only comes every couple of days, they're not exceeding the limit of until the prescription gets canceled, but they are consistently missing doses. Do let the doctor know that you do notice this pattern. Rapid access clinics are actually becoming more prevalent, and they are mostly attached to hospitals. If you do a quick search online for RAMS clinic, they do have all the location listed as well as the hours, which is quite convenient. Never a bad idea to keep that in your resource book so all your team member can access it quickly. I'm not going to go into the details of the missed dose table. They are available in the books that I had mentioned earlier for the pharmacist guidebook. I do keep it very handy in the dispensary, just so anyone who needs to check can pull over the book and review it quickly. Now for observed dosing, we check for those drug interaction. You have confirmed the patient either by ID, or if you have a photo in the dispensing software, that's great. It saves the ID checking time as well. You can also confirm the dose with the patient, because they sometimes get the more up-to-date information. Like say they just come back from the doctor's office and they told them to increase or decrease. You might not have received the prescription yet, but the patient already let you know. So that's when you notice that the dose you have on file may not be the most current dose. So always good to do a current check, like a dose check, right before you give the dose to the patient. For the methadone therapy, you will observe the client to drink the entire content of that drink. Some patients do complain that the 100 ml is too much. Do give them a little bit more time so they can take up to like 2-3 minutes to drink the whole thing. If they don't like it cold, you can also leave it out at room temperature like earlier in the morning before they come, so they don't have to drink it cold. Things like that, but you just want to keep the volume consistent. You can also offer some water or extra juice to rinse the cup after. And the most important thing is actually get the patient to speak after the dose is taken, just so that you know that they have swallowed the whole dose and not cheating anything. For buprenorphine therapy though, before you offer the tablets to them, just check in with them to see if they need water to moisten the mouth. If their mouth is very dry, it does take a lot longer for the tablets to dissolve. So after they put the tablets under their tongue, you can do 2 checks. One check at around 1 to 2 minutes mark, where they open the mouth and you see a mushy mess. You cannot retrieve the tablet out anymore, so there's very low risk of diversion. Or you can wait until the very end once they finish and sit for like about 5-10 minutes until the tablet is fully dissolved, and you check under their tongue, there's nothing left, and they're free to go. There are clients who are always in a rush. You can do a 2-minute check like once in a while to let them go earlier, but it should not be a consistent practice. And also advise the clients do not drink anything for about 5 minutes afterwards. Again, we just want to ensure everything stays under the tongue and absorbed there. Anything that they swallow is actually not very useful for them. I hope the buprenorphine takes a little bit longer than 2 minutes to dissolve. If they dissolve any faster than that, I did have clients who consistently had dissolved those tablets way sooner than what it should be. And then when we check in with them about a month later, they did express that they do experience more craving, some withdrawal symptoms. And then we explained to them, maybe allow a little bit more time to hold that mushy residue under their tongue for optimal absorption, and that might help with absorbing the dose. Finally, there's a signature piece. This is more relevant, I guess, before the pandemic. We always ask the client to sign off that they received the dose. Depending on your pharmacy practice, this is optional now, but you still do want to have a record of that the client did come in. Sorry. So caries. So this is also a hot topic for me as well. Patients should be given sufficient caries to last until the next scheduled appointment or observed dose. What that means is that, back to our example of observed Monday and Thursday, on Monday you'll give enough caries until they come back on Thursday. Don't give a full weeks of caries because you won't see them on Thursday. You will see them when their caries are finished. So always just give enough until they can come back. Of course, with the current situation, there are increased number of caries. There's actually no maximum number of caries that you're allowed to give, but you can give 1 month or 2 months if that's what the prescription calls for. However, if you do suspect there are security issue, especially for someone to keep like 2 months worth of caries with them, they may not have enough refrigerator space or there's security issue, then it's up to the pharmacy discretion to dispense less as well. You don't cancel the prescription, you just dispense more frequently, but less quantity at once. Lockbox is actually best practice, it's not mandatory. Again, going back to the security issue. Do you know if the patient is living with somebody who may go into their belongings and use the methadone juice or the buprenorphine supply inadvertently? Say for children or for elderly, because when you put it in the fridge, it kind of looks like everything else. If those are the case, then the lockbox is recommended. They don't have to bring it to the pharmacy to show you every single time. You just want to keep reminding them that this is high-risk medication. It's best to lock it up so no one else can access it. Bringing a lockbox to a pharmacy, sometimes I feel like it draws more attention than it should be. If there's other way for them to transfer those medications securely, that's fine. So for methadone, again, we just said that like it has to be 100 ml dilution, and each dose has to be its own bottle. But for buprenorphine, you don't need to separate out the daily doses. Delivery-wise, this has changed a lot as well since the pandemic. It used to be only under special arrangement agreed upon by the prescriber and the pharmacist dispensing. These days, you could deliver both methadone and buprenorphine therapy as long as you can ensure chain of signature and the right person is receiving it. In terms of observed dose, I will leave that topic out as well for the presentation 2 weeks later, because it does go into a little bit more detail than that. Transfer of custody is something that it's not as common in GTA, I would say. It's more so in the more remote area where you have to transfer the methadone doses to someone that does the job for the pharmacy. It could be a prescriber or any other regulated healthcare professional that is delegated by the prescriber. So what this transfer of custody means that this group of people will receive the doses from you. They have to track the movement, so the administration, whether it's wasted, given out, or partially complete, and they have to return all the unused doses to you for destruction. These serve as your pharmacy record, so you're kind of passing on the responsibility to them, and they have to do the job for you. Make sure you have clear policy and procedure if you're doing so. However, if you're getting a call from like long-term care facility or hospital or even correctional facility to get the methadone doses from you, those are not considered transfer of custody because you don't need any record, like administration record back to them. You're clearly fulfilling the order, where a controlled substances order, where you want to ensure the delivery has a chain of signature and you do pass it on to the right people. Okay, so inventory management is very, very important. As per OCP guidance for controlled substances, you only have to do 2 complete cycle count a year. However, if you do dispense methadone and buprenorphine frequently or even on a daily basis, a more frequent cycle count is better. Even on a daily basis or weekly basis, you just want to maintain that accurate inventory level so you can always go back and investigate any discrepancy as soon as possible. And just to make your life easier, you want to keep the minimal amount of stock and these brands available. I know clients may always ask for like, this brand of buprenorphine tastes better than the other. Keep it consistent, just stick with one brand. Otherwise, you'll have a lot of time like looking after which patient gets what brand and why this brand missing 2 tablets, but that brand has 3 more tablets. For methadone as well, you might also get this loss in measurement. So some volume do get lost if you do use different type of devices. The volume, it could be spilled or it could be stuck to the walls or the tubing of the device. Sometimes you keep changing the bottle, that remaining little bit of volume do get lost as well. During your cycle count, do document those loss in measurement. It should be consistent throughout the month or like between months. If you do weekly count, say like you lose 5 ml, documented 5 ml loss in measurement, and it should be consistent over the next few weeks. If all of a sudden in 1 week you get like 15, 25 ml of discrepancy, that's something that is worth investigating. For those loss in measurement volume, you do not have to report it to Health Canada. However, for any unexplained loss, you do have to report it to Health Canada within 10 days. So my recommended cycle count frequency is actually on a weekly basis, so you can catch up to those timelines. So documentation as well. We have touched upon this previously. You just want to have something that you can reference back quickly for missed doses. Some pharmacies use hard copies or like their electronic copies now to see whether the client come in on a daily basis. Some pharmacies actually keep patient-specific logs or calendar logs, just so they can have a quick glance of what has been missed throughout the week and whether they have to notify prescriber for any missed doses. I'm going to go through a sample quickly just to see how these look like, and you can decide if you want to adapt those for your pharmacy as well. So this is a patient-specific log. You can add in any relevant information that the team should know about, like this person always gets the observed dose on the weekends from somewhere else. You can have a picture of them, so for easy identification. But every day they come in, you just write in the line of how many observed dose they got, how many carries they got, and you sign off. And you can also have the timing there as well, so you know it's not 15 hours or earlier for their next dose. And some pharmacies decide to use a calendar log. And this example is a weekly log of for Monday to Sunday, or if you want to do Sunday to Saturday, you can list all the patients that's coming in for that week. So it could be like 5 to 10 patients, an easy glance of which patient is coming in on what day and whether they have missed the dose the previous day or picked up from somewhere else. And finally, it's the returns. You don't have to ask for patient to call back, like come back with the methadone bottle and show you that they did not open it, they still have the doses. This is done by doctors. Of course, they can specify in the prescription to ask you, every other week, do a callback check with the client where they have to bring back all the doses they have remaining at home just to make sure that they they are following the instruction accordingly. But you could also ask the patient to return any empty bottles before issuing them new carries. So you make sure that they didn't really divert it and they are returning the right quantity before you give them the new carries. This too also have changed a little bit during the pandemic, so we'll cover that another time. For disposal though, you do need to follow the OCP and Health Canada policy on disposal of controlled substances. There's two types of disposal. Unserviceable stock, which means these inventory still resides with your pharmacy. They are from your safe, they're either expired or damaged or can no longer be used. If you're destroying unserviceable stock, they have to be chemically destroyed with 2 witnesses. So you basically add some soap, mix it up. There are other fancier marketed product to like gel everything up. If your pharmacy use that, that's fine as well. There's another type of return called post-consumer return. So these are things that you have already dispensed to the patient, but they no longer need it, and they return it to your pharmacy for destruction. That is fine as well. There is company that offer free return service and destruction services, and it's available on the OCP website as well. Both of these, especially the post-consumer return, there is a hole currently due to the pandemic situation. So change of dispensing services, this is talking about if you ever decide to change your service of methadone dispensing, you do have to notify OCP. That includes discontinuation of dispensing or change of hours of operation. This obviously has changed a lot during the pandemic just because our hours keep changing just to fit the needs of the clients or the risks of the current situation. Whenever you have these change, make sure to inform the patients just so they have enough time to make the arrangement. If they need to find another pharmacy, you might even need to have a list handy so you can refer them to it. And finally, if you work with a prescriber, methadone prescriber, buprenorphine prescriber a lot, it's never a bad idea to let them know that your hours have changed or your service have changed so they don't keep referring you clients that you might not be able to serve. And finally, just some additional resources. If you ever need to call someone up or look up information, these two are the quickest tools that I find. And of course, having some of the references that I have listed previously, they do answer like many questions that I get usually. So that's the end of the presentation before we go into a case scenario. I know I'm a little bit tight on time, so I want to make sure that everyone it's okay with the questions, anything urgent that you want me to answer, I will do it now before I dive into the case. If you're not able to stay for the full case, I understand that this presentation is recorded, and so you're more than welcome to come back and listen to it a little bit later. So I do see some of the question now. When dispensing methadone tabs only, do these regulations apply to the pharmacy? Methadone tabs are not commonly used for opioid use disorder, and they're not appropriate for opioid use disorder. If they are being prescribed, they're mostly used for pain management. Then these regulations do not apply in terms of like billing wise. You don't need to observe, so you only get one dispensing fee for dispensing that bulk of tablets. If patients are going on traveling, it's not appropriate to switch them from liquid to tablets due to diversion risk. So we reserve the tablets really for the use of pain management only. Where does it say you can take a verbal RX for methadone? This is actually a new thing since the pandemic has started, where they have provided all the exemptions for controlled substances, where pharmacies can receive verbals, can transfer controlled substances. So those are fairly new. They do have expiry date. It doesn't mean indefinite. The current expiry date, I believe, is next October. So for the time being, pharmacy are allowed to take verbals for methadone and for controlled substances in general, including methadone and buprenorphine. But again, like whenever you receive verbal, especially for controlled substances, you also want to make sure you have a way to check back with the prescriber, making sure that prescriptions are valid. It is a prescriber calling you, not someone calling you from a random cell phone. And in a very busy pharmacy, it's very difficult to watch observed dosing for 2 minutes. Completely understandable. I cannot keep my eyes on some books and papers for more than 2 minutes too. It's not something that you have to stare at them for the full duration where you observe them. For methadone, it's good to watch them to consume the whole dose. It doesn't take too long. For buprenorphine, once they put the tablets in their mouth, they usually settle into a seat or they might take a walk. And you call them back in the 2 minutes time to make sure that they have something dissolving in their mouth, or you wait until the very end to check that everything in their mouth has been dissolved. And that halfway check on buprenorphine is not mandatory. So that 2-minute check of mushy mess is not mandatory. It's really depends on your practice. If you're very busy, you have like 5 other patients to look after, and you might not be able to check in on them or remember that they are still around for the next 15 minutes. It's good to, if you see them around, just ask them, hey, can I just do a quick check with you? How's everything going? And at that time, you can do the 2-minute check. But if you want to leave everything to the end, that's fine too. And if you want to do more than one check, that's more than welcome too. Okay. Sorry, I'm just scrolling up just to make sure that I have answered all the questions. Can you put the tablets in the original box? What if you, I'm assuming this refers to the Suboxone tablets. The answer is no. So child-resistant cap is mandatory. If you decide to waive that child-resistant cap requirement, this is on the pharmacy, so you will bear the risk if the tablets are inadvertently got administered to someone else or picked up by someone else. Okay. I think some of the questions I've answered. If I have not, feel free to type them out again and I will go over those. How do you refuse to give a dose and what happens after? So this is one of the difficult conversations that hopefully not commonly encountered, but I think common enough. If for whatever reason you want to refuse giving a dose to the client, you have every right to say so, either because they're intoxicated. This is for their safety reason. Whenever they're looking intoxicated, even though they verbally deny it, but you have reasonable grounds to smell alcohol, they're falling asleep, you do not want to give that dose, that's fine. Document it and you can report it to the prescriber. They are obviously not in the mood of having that negotiation with you at the moment. So at that time, you can only say that, sorry, I cannot give the dose to you for today until I check in with your prescriber. You could either wait here until I can reach the prescriber, or you could come back another time or wait for my call until I can contact the prescriber. But unfortunately, if they're not feeling well, it's not safe for them to consume the dose, do not give the dose. The conversation will be difficult and they're not going to be receptive at the time being. It's something for you to revisit with them at a later time when they're sobered up, when they're ready for those conversations, and of course involve the prescriber because they have every right to know and have that conversation as well. Okay, so I think I've covered most of it. When do you wash methadone carry bottle return? And how do you dispose of methadone carry bottle? I think that was one of the questions. So return methadone carries are part of the post-consumer return. You can leave the entire bottle in that collection box, black out the label of the name, and then the company will take care of it after. Usually they box it up securely and send to incineration. For washing of the methadone carry bottle though, I don't want to say that pharmacy have to do this. If they are returned with the full bottle, you can dump it with the rest of the controlled substances and chemically destroy. So add some soap, add some other bleach or whatever in there. But if they only have a little bit of juice in there, you can add some water in it and then leave it for the collection box. But you do not need to wash the bottle for the patient, especially something returning from the patient at this time. Right now, if you do advise the clients to dispose of these bottles at home, they can definitely wash it at home in their sink. That's fine. Just make sure they run enough water to like wash all the remnants out afterwards. But there's nothing special about washing out the bottles. Really, it's just try to dilute it as much as possible, and so no one can collect the remnants after. Destroying at home, there's the environmental impact, so that's why it's not as good. But during this pandemic situation, that's the only option we have. How do you wash? What if they miss 2 carries? Do you wash them? What do I do with the methadone? I'm not quite sure if I understand you correctly, Elizabeth, for the methadone wash. In terms of chemical destruction, you do it same as the other controlled substances. It might be in the liquid form, but if you pool enough controlled substances together, then you can chemically destroy them all together. So I see a few of you, actually many of you are still with us. So I just want to take this opportunity to run through the case quickly. At least we have something to go over in terms of example. So for the case, I just want to introduce it as it's a 3-part case. It's fairly long, but I want to cover all the material that we have talked about and put it into context. So the case is about a 33-year-old female who has recently moved from Alberta. For good reasons, she has come very prepared. She has come into your pharmacy early before her dose is due. So the prescription is from Alberta, written by her usual prescriber, as all the legal requirements for the prescription, and matches the patient. It asks for 35 milligrams of methadone once daily, observed on Monday and Thursday, and carry for the rest of the week. It's 6 p.m. on Tuesday only, so she's not due for her dose, and you have confirmed with her that she has enough carries until Thursday. But she's here. Just want to let you know she has picked your pharmacy to be her provider, and she'll be coming back Thursday morning for her observed dose. What would be your next step? So I'm so sorry that I ran over time. So for the time limit reason, I'm just going to jump straight into the discussion points. But feel free to share your thought in the chat box if there's anything that you can think of that's not already listed here, because I think more brains is always more useful than just mine. So some of the discussion point that I will want to go over with MH. Since she's here early, you already have the opportunity to discuss with her. You want to collect some background information so you don't spend as much time on Thursday morning to do so. So you may want to ask MH all the relevant medical information. What is she using the methadone for? You want to get the previous pharmacy information because you can use the time to kind of call them back, confirm the details, last dose information, and so on. And since they're here, you can also collect any insurance information and do some billing testing to make sure everything goes through fine for Thursday. You want to give her a treatment agreement. You might not be able to go over every single point on there with her, but at least print one out for her review for the over the next 2 days or so until she comes back. It will save you guys both time in terms of reviewing every point together. You also want to give your phone number or the pharmacy phone number to MH in case she has any question that come up before she returns. And if she's willing, she can also you can also ask MH to bring back all her carry bottle on the day of observed dose, just so you can be sure that she has consumed the doses prior to getting new doses at your pharmacy. And you may also want to check who is she living with right now. If she's in a new residence, does she have a new phone number? Is there any risk of people that are living with her having access to medication such as methadone or buprenorphine? So Thursday morning, she comes back as promptly as she can, just first thing when you open. It happens to be you on duty again, which is great. She looks fine. She show her ID. She proves that she's MH, and she's not showing any signs and symptoms of intoxication. She also brought back the 2 carry bottle as you had asked her to, showing that she did consume her carry dose and is ready for the Thursday dose. But she did mention that she is in a rush to get to her new job by like in a short amount of time. Your colleague on Wednesday also happened to call up the Alberta pharmacy and was able to confirm all the details of the prescription. Everything matches what MH say. There was no missed dose. There's no important notes about MH's behavior, except that she could be getting anxious easily. There's no one else waiting in line, so you go ahead and prepare the methadone dose for MH. What would you ask MH in your counseling area, and what would you discuss with her? So some of the discussion points that you will want to go over on the day of the observe is that you first want to review the treatment agreement. So if on Tuesday you have already handed her the copy, she has signed off and bring it back to you. That's great. But sometimes people sign things and not really read through everything. So you just want to go over at least the key points with her, making sure that she understands that the hour of operation, the basic expectation, the mutual communication, and any communication with the doctor. When would you notify the doctor? That kind of thing. It could be very quick, but you just want to lay that foundation out there, especially early on in the relationship, so there's no surprises down the road. And then dose administration, as we have said, you will watch her consume the whole dose. You will review. I also like to just pick out all the carry doses and review it in front of her, telling her like, this is Tuesday, sorry, this is Thursday. So this is Friday's dose, this is Saturday's dose, and where you will find the ingestion date. Every pharmacy might label their products a little bit differently, so you might want to point out those for her if she's a new client with you. She also mentioned that she's going to work. So does that mean she's bringing these carries with her to the work? If so, where is she going to keep them? Will there be any risk of someone having access to them, or someone drinking them inadvertently? So you want to just go over that with her. And finally, if she's willing, you can also ask her for photos, so you don't have to keep checking her ID every single time. If you have carry bottles with correct date, do you still need to confirm the last dose with previous pharmacy? Cynthia, that's Cynthia's question. I would say yes, because again, the dates on the bottles are just dates. When you hand these out to the client, they could have taken them on a different date than what is labeled for. Of course, the trust is you and your client, how much you can take her words for. But especially if they have went to other pharmacy, you also want to give them a call and just making sure that they had pick up only those amount of carries and not more than what they need. And then also notify the other pharmacy that she will be using your pharmacy service for a day or two or from now on. And we're at the final part of the case scenario, and then I will let you go. So case scenario part 3, it's been 2 weeks already. Everything is going fine. MH has been sticking to the therapy, coming in on Monday and Thursday religiously, and no issues so far. But during today's encounter, you did make a comment that her prescription is running out, the one that's written by her Alberta doctor. And you have asked if MH has any plan to see a doctor in Ontario and get the next prescription. She is obviously getting a little bit anxious, not knowing that, she had to do that, and where to find a new doctor because she hasn't had time to do so. And she also made a comment a couple times in passing that the drink is really too big and it makes her feel really sick. Drinking all that orange juice in the morning. What would be your recommendation as well? So in terms of the prescription issue, that was obviously a little bit more urgent. If the prescription is running out soon, you can obviously suggest one of the RAND clinics for MH to get by and find a new doctor. Some of these RAND clinics do become the patient's regular doctor as well, if they're not able to find one elsewhere. So that's probably the first and foremost thing that you want to introduce to MH. If MH cannot take time off work to visit one of these clinics, suggest MH to also call the Alberta doctor back to just explain the situation to them and see if they can do a phone assessment and issue a prescription to your pharmacy for the time being. You should leave this to MH to do though, because again, there is that doctor to patient assessment that has to be done, and the pharmacy, it's good to send them the notification, but in the end, the doctor still need to talk to this patient before they can issue a prescription. So you will explain to her again that the drinks have to be 100 milliliter in volume. If it does take, if it's a hard time drinking all that juice in the morning, you could offer to ask them to come in a little bit earlier and take a little bit longer to consume that drink. But you should not reduce the volume unless there's other medical reason to do so. She did mention she's trying to lose weight, so if calorie is a concern and you happen to have Crystal Light around, you could substitute that as well. Confirm with MH whether she has consumed the entire drink for the carries as well, because she did mention that volume is a concern. So when she's not being observed, you just want to check in. Have you actually finished the whole drink? Because that's your entire dose. If you don't want to drink so much volume and thus drinking less, then you're not getting the full therapeutic effect. And finally, although you are saying no to patient, it's a difficult conversation whenever we're saying no, but you still want to engage in those conversations. Just make sure that to show that you are listening to the patient, you are engaging them in their therapy. Not everything they ask for will be a yes, but at least these are some room for discussion, and it does show that you are supportive in their recovery. So that covers all my discussion points for this case. It's a relatively oversimplification, of course, to everything that you get in your pharmacy. But hopefully some of the pointers could be elaborated a little bit more, and you could use them in your pharmacy practice as well. And I will share my email if you do have more questions. Feel free to email me back. I believe Alan and Angie will also send you the evaluation form and the slides. If there's any question that I found that being asked a lot, I will share those answers in the email as well. Everyone, it's a Sunday morning, and here we are talking about oats. So as Angie has introduced, we'll be here until about 11:30. The presentation itself takes about an hour and 10 minutes. I will try to wrap it up as soon as possible.